Again, students, racing against time for students in pathology, R.A.T.S. One topic that was a little weird was the carcinoma of the endometrium, which I saw in the panel of university questions. This is important for pathology as well as OBG. Let us see what it has got for us. A case history. A 50-year-old female presented with an abnormal uterine bleeding. Her estrogen levels were high. All body scans showed a 15 centimeter solid and cystic lesion in the right iliac fossa. A hysterectomy with BSO, that is bilateral salpingo-oophorectomy, was performed. What are the probable coexisting tumors? Describe the pathogenesis and the morphological features of the lesion in the uterus. Diagnosis? Yes, it is endometrial carcinoma. IQ is equal to UQ. Nothing to beat this, except probably this. Students do not resort to shortcut answers that will lead to long cut in marks. Endometrial carcinoma. One of the most common features is that it is in the age group of 55 to 65 years, a common tumor of the female genital tract. And there are two basic categories, namely endometrioid and serous. Apart from that, there can be the clear cell and the mixed Mullerian tumor. These are relatively rare. We shall be concentrating on this. The endometrioid carcinoma forms 80% of the cases. This is due to an estrogen excess and occurs in perimenopausal women. Perimenopausal means just before and after menopause. And why is it called endometrioid? Because the tumor glands resemble the endometrial glands. The risk factors again: obesity, diabetes, hypertension, infertility, and unopposed estrogen. Unopposed estrogen, it can be exogenous or endogenous. All these can lead to an endometrial hyperplasia, atypia, and carcinoma. And the tumor suppressor gene in this case is P10. Any mutation in this P10 leads to a carcinoma of the endometrium. TP53 is also important, but I put only 1 star for it and 3 stars for P10 because P10 is much more commonly involved in endometrial cancer. Another type is the serous tumor. It forms about 15% of the endometrial tumors. It is associated with endometrial atrophy, so it occurs in older menopausal women. The endometrioid cancer, it occurs in the perimenopausal women. Here it occurs in the postmenopausal women and not associated with endometrial hyperplasia. Here the main defect is in TP53. There it was in P10. P10 is relatively of a lesser significance in serous tumors. The gross description, let us consider equally for both. So this is a uterus, the ovaries are here. The uterine cavity is completely filled with the tumor. The arrow is pointing out to it. And it is bulging, it is showing multiple papillary projections, etc. We can say it is a proliferating lesion. Sometimes it can be infiltrating also. It varies in size from a few to several centimeters. Friable. The friability you people can appreciate in the picture itself. The uterine wall can be thickened due to the infiltration of the tumor. What is this infiltration? We shall see. Look at this one. Here again, I'm finding multiple projections. It is a cut surface. And this is the uterine cavity. The tumor is seen infiltrating into the uterine wall. It can be seen in small tufts or in papillae. The arrow is here. And microscopically, there will be atypia of the cells, increase in nuclear cytoplasmic ratio, and mitosis. P53 is positive in IHC. This is due to a mutation in the TP53 gene. In the serous type, there are multiple papillary projections. Serous type, endometrioid type. There are two types. Here I am finding multiple finger-like projections. There is a central fibrovascular core, and these are the tumor cells. Since it has got finger-like projections, it is called as papillary. Endometrioid, it more or less resembles the glands of the endometrium. So here I am finding the glands. The tumor itself is composed of multiple glands that is infiltrating the stroma. So microscopically, these 2 points alone you remember, endometrial gland-like, and then serous is papillary or finger-like. Endometrioid resembles the endometrium. There are two patterns. One is exophytic, growth into the lumen, infiltrative, growth into the wall. And the histological types are mucinous, tubal, squamoid. These, if possible, you can remember, otherwise fine. This picture depicts the staging and the spread of the endometrial cancer. It originates in the endometrium, and you find that it can spread linearly to the adjoining region, or it can infiltrate into the adjacent organs such as the fallopian tube, the ovary or the broad ligament, and the vagina. There can also be distant metastasis. So please remember this box alone. It can spread to the cervix, the vagina, the lymphatics, peritoneal, and the lung. So these are the sites of metastasis. Kindly mention it. What are the methods of diagnosis? For diagnosing any of the endometrial lesions, we can do what is called as a hysteroscopy. A hysteroscope is an instrument that when inserted into the uterus, it can be visualized what the lesions are. And there is also a spectrum that is used for dilatation. Also, you find that there is a provision for a biopsy which can be done. So here I am finding the uterus that is being examined by a hysteroscope. What are the methods of diagnosis? Hysteroscopy, histopathology, ultrasound, and MRI. These are the various methods of diagnosis. What are the manifestations? The patient has got irregular postmenopausal bleeding. Uterus is enlarged. There is addition to the adjoining structures. And the modes of spread will be into the myometrium, vascular, and lymphatics. Prognosis, the endometrioid carcinoma has got a better prognosis than the serous. The treatment of choice will be surgery. A radical hysterectomy is done, and a hormone therapy can be given adjuvantly. So this is another picture showing the different spread and a lymphatic spread of the endometrial cancer. This is a beautiful tabular column I picked up from Robbins and Cotton. These are the differences between the endometrioid and the other type. So in endometrial type, you find that there can be a hyperplasia, and these are the P10 and the KRAS are the markers. It is less aggressive when compared to the papillary type. You find that the endometrium is showing a malignancy. P53 is the more prominent marker, and it is aggressive, carrying a poor prognosis. Please by heart this tabular column. It is a summary for you people. Another lesion is the mixed Mullerian tumor. For the sake of completion, just 2 slides. MMT, mixed Mullerian tumor, or otherwise called as malignant mixed mesodermal tumor. It contains both a carcinomatous and a sarcomatous component. It forms only about 2 to 5% of the uterine malignancies. The sites are usually the uterus, but it can occur in the ovary and the fallopian tube. And these are the risk factors. We had seen the first 3 earlier, but it can occur in radiation as well as tamoxifen therapy. And this is the tumor. It is ill distinguished, it is infiltrating, and it is showing some areas of hemorrhage. Microscopically, I find that there can be a glandular epithelial component, hence it is a carcinoma, or there can be spindle-shaped cells with mitosis and atypia. Therefore, it is a sarcoma. Both carcinoma and sarcoma are there. So it is a carcinoma sarcoma lesion, otherwise called as triple MT. The origin is supposed to be from the Mullerian duct, and it can also be from a stem cell.